So today on Doctors Unscripted, we have Dr. Mark Wang from DISC. We're excited to have him on. He's an orthopedic surgeon who specializes in any type of degenerative spine. So welcome to the show. Happy to have you on.
Thank you. Happy to be here.
So background then, Stanford for medical, UCLA for medical school, Stanford for orthopedic residency, correct?
That's correct, yes.
Awesome. So as far as going through that program, obviously it's a very rigorous and high-profile program. What are some of your favorite things that you saw in school that maybe you miss a little bit now that you're in practice?
I mean, I think there's trying to figure out what you want to do, when you grow up is always a thing. And even in orthopedic residency, you actually don't know what you're going to do the moment you step in unless you pre-plan your life. So it's always a nice thing to reminisce upon how you got to where you were. So I was lucky to have a really good mentor at Stanford who really encouraged me to kind of challenge myself, and he felt that spine was probably the best place to do that. And ultimately, that's how I ended up doing it.
That makes sense. I sometimes catch myself thinking back to university and like, oh man, there was like no stress back then, like how nice it was. But in reality, every phase of our life, when we look back on it, we see it in the shining haze of memory and not the stresses that we were actually going through. So now that you're in orthopedic surgery, what's one thing that maybe is different than you thought it was going to be when you were in school?
Well, I think the one thing that medicine or medical school definitely does not prepare you for, and residency certainly doesn't, is the aspect of media and business that's associated with medicine, right? Yeah. There's a huge amount of misinformation, right? And even on the business side for physicians that we don't have an understanding of. So there are a lot of pitfalls that we can walk into that we don't understand. And so I think the goal today to educate both our patients and future physicians is that, medicine, for better or worse, is going to be integrated with industry and other practices. And we have to know how to navigate that in a way that's, financially, not putting ourselves at risk. But that's not something we get educated on. It's something that you figure out along the way, and hopefully it's not because you got punished.
That's a great point.
Yeah.
So as a successful orthopedic surgeon, what advice would you have to other doctors that are either just getting started or already in practice on how to navigate that conundrum?
I think talk to as many people as you can, right? And people that you trust, and maybe even people that you have heard things that may not be as savory about, because the reality is there are a lot of people who say a lot of things that don't mean a lot. And the only way you're going to figure that out is if you speak to everybody, right? You don't know, what's really behind the scenes. And there's a lot of, especially in small towns, right? People will say a lot of things about other people, other physicians. And you really have to take that with a grain of salt. You really got to explore that on your own. So I would advise everybody to talk to as many people as they can if they have questions about their practice, about the environment in which they practice, and where the direction of their practice is heading. The only way you're going to get that is more conversations.
No, I love that. I feel like there's many times where I've heard something about a doctor before going to dinner, and I'm like, you know what? I'm going to reserve my judgment for myself when I meet them, and I go and meet them, and they're a fantastic person. Yep. It's like, there's two sides of that. Like, everybody has different experiences with people, and then there's also the fact that there are successful doctors that people do get jealous of, and they're willing to talk poorly of, and then there's really people that are maybe not the best people. And so the only way you're going to know how to distinguish that is spend the time, do the work, make your opinion for yourself, and I think that's the best advice possible. So going from there then, in business, because healthcare, there is a business in healthcare, and I actually think that the people that suffer the most are when doctors don't embrace the fact that business is in healthcare. And my opinion, which it's only my opinion, is that the best way to really integrate those is through education. And so one of the things that we do, like this podcast, is we believe that when you increase communication, increase education, talk about things that for a long time people didn't understand and try to make them more accessible, the better the educated the patient, the better care they can receive and the better decisions they can make about their care. And so I believe that as it goes to going out and marketing and building the business, one of the best things you can do is provide real educational content that's going to, stand in contrast to some of that disinformation you were talking about earlier, but also stands as a pillar of this is good data to go out there to educate and empower people to make good decisions. What are some of the things you've done to try to build your business?
I think we have tried to kind of put ourselves out in the community and try to be as responsive to our patients' needs, and even people who aren't necessarily our patients yet, right? To give them potentially a different option than what might be more traditionally out there with these sort of bigger, larger hospital-based groups. Like you said, medicine is ever changing, and certainly in the world of subspecialties, there's been a lot of sort of conglomerations for hospital systems, even purchasing groups and then kind of aggregating them, and so you're losing a lot of this individualness, right? Yeah. But individualness is generally what drives innovation and competition, and generally success, in my opinion, especially when you're dealing with things that are as technical as medicine and surgery. And so if you commoditize specialty, you're going to get maybe a more efficient level of care, but not necessarily the best level of care. And I think our patients deserve the best. So we try to, on our website, promote all the types of different operations that we might do that isn't done at a different group. Such as endoscopic surgery, some of these minimally invasive techniques that some of these other practices may not have been doing or have not been doing as long as we have, and really just giving patients the option to choose, an alternative. And I think being able to give people that opportunity to pick and choose and not force them into, I have to go with this system because this is what my insurance dictates. I think patients then can make the better decision about their healthcare. And generally, when the patient is also participating in driving their healthcare, the outcomes are better.
No, I 100% agree with that. And one of the things that I've really been impressed with is, like, I looked at your website. Your website's fantastic, by the way. And like we try to do a lot online to educate and look at that and have a good website. You guys did a great job on that. And one of the things that I saw on there is, like, you have this virtual consult, like get a second opinion, and you can do it virtually. And it kind of goes back to what I was saying earlier is I do believe that when you have good business foundation, healthcare gets kind of unleashed. You will have, there's doctors that are incredible doctors, but because they don't have good business systems, they're not seeing a lot of patients, and the patients have a bad experience, not because of the doctor, but because they sat in the lobby too long, and the paperwork was too much, and they had a terrible customer experience, even though the doctor's amazing. And so I feel like the best practices do both really great. They're incredible doctors, but they're also trying to create an incredible experience for the patient to go through, not just focus only on the healthcare, but both are important.
I think that is becoming increasingly difficult to obtain, especially in these larger systems, right? If you can walk down the street and find a group of 50 orthopedic surgeons right now, where you're treated like a number, right? And that's just partly that's the efficiency. They have so many people coming to see them because they're so big that it's almost impossible to give them this sort of like curated experience of being at ease. But going to see a physician, whether you like it or not, is a nerve-wracking experience, right? It's not just because there's great news to be given to you. There's something that is not working or not right at the moment that you hope can be fixed. So to come into a situation where it's fairly sterile, you're treated more as a commodity, is probably not the most ideal situation for somebody's anxiety. Whereas if we try to be more conservative with our approach, see fewer patients but give them sort of our full attention, even if it's for that 5 minutes, you give them the full attention, it's better than spending 30 minutes ignoring somebody. So I think that's our sort of motto, and it just happens to be that our partners all kind of are in that same belief system, which is why we all get along. But it would be hard. I would be hard pressed to find 30 other guys or women to put in the same office and expect everyone to have that same, ideal. And I think that's probably why we've held out from joining, a mass group, because you worry that we're going to lose either some of that special sauce or just the personal sort of attention that we give to our patients, and they appreciate it. I mean, the vast majority of patients that we see, we don't operate on, we don't treat, we don't do anything other than give them guidance and then let them find their way. But they're very happy with the treatment that they've given, because that's treatment too. It's not because you just operated on
Listening
somebody.
is treatment.
Yeah. So
one of the things that you said that I love is talking about, like, they say that your most limited resource in life, your most valuable asset you have is your time. And I actually disagree with that slightly and say the most valuable asset you have is your attention, because you can spend time with someone and completely ignore them, and it means nothing, right? You can have a 30-minute consult with someone and not pay attention, but it's the quality of that time, the quality of that attention. So I love the fact that you're saying, like, with your group, it's spend that quality, focused attention with the patient, and that's where you're going to get the best outcomes, because patients are going to feel cared for. But you did bring up another topic I'd love to kind of move on to. So we're seeing this really I shouldn't say dangerous trend. We're seeing a trend in healthcare with consolidation and roll-ups of clinics. We're seeing big practices getting bought by hospital groups, big practice being bought by healthcare, health insurance groups. You're one of those premier facilities that has that has a great reputation, doing a lot of good work, but you've managed to stay. I mean, you're not tiny. I think you have 5 orthopedic surgeons, but you've managed to maintain a great reputation with great resources, with a great website, while also being smaller than some of the huge competitors out there. So what do you feel like is some of the dangers? And we touched on some of them already, but what are some of the dangers involved in that consolidation?
Well, I think you have to look at it in kind of 2 ways. I was talking to another surgeon who's part of a group in the northern part of Arizona, in a good group. And his concern was that we're doing great now. But what does that mean for the future, right? And for partners who have been there for a long time, it's okay to do great now because you're just churning and you're making income and revenue, because your runway is not as long and you're happy about what's happening at the moment. But for younger folks or people who are in the midterm of their career, if you don't have some sort of vision, then you can run it, but it's only going to run as good as it runs today, right? It always gets less efficient as the days wear on. So we have to have some vision. And the fact that negotiating powers probably are our least effective attribute when we have 5 guys. If we had 500, regardless of whether they were good or not, in the eyes of the insurance companies, in the eyes of the commercial payers, that's what counts. And so we have to navigate this where how can we possibly have 500 people that we trust to give people their time, give us their time, provide good care, and yet still be able to utilize that denominator to negotiate with people who essentially pay us our salaries. And that is where I don't know the answer, because you're right. The reason we have stayed away from that is because we do a good job, and we get rewarded with that, with good patients, good referrals, and working with people such as yourselves. So if we have opportunity to do that and basically practice medicine, then we don't think so much about the other side, which is what happens, But if we stop and we don't think about that, then I do think we're going to have a problem in the next 5 years.
Yeah, I look at that and I say, so the danger is that as you grow, the quality can go down, right? Because it's really easy to ensure quality on small scale. But as you grow, the problems become more complex, the dynamics between doctors become more complex, and the quality standards absolutely can fall. Now, it doesn't mean they have to fall, but there's a chance of them falling the bigger you get, and I agree with that. But you also touched on exactly the reason why most doctors do join a big group, which is the fact that, hey, insurance companies value negotiating power, and when you can go to them and say, we have a huge group of providers, we need better contract rates, they're more likely to get it because they're saying, look at all of the different providers we have, and there's negotiating power. That's why unions have power, is because there is power in group negotiation. So I'd love to talk a little bit about some of the strategies that can be employed for smaller practices that are trying to give quality, high level of care, but also want to say, if they're getting paid twice as much as I am for doing the exact same amount of work, it's really hard to be competitive.
Yes.
So how do you stay competitive as a small group to be able to not just stand on your laurels with quality of care, but also make sure that you can, have a successful business that allows you to keep the lights on and keep delivering high quality care? I
think you have to then play the game a little bit, meaning that you are going to have to align yourself with either a larger resource that can sort of create that negotiating power for you, or create one. Obviously, there's only 24 hours in a day. So if you're going to spend the vast majority trying to take care of yourself mentally and your patients, physically, then, there's that small other, subset that you can either rest or you have to keep pushing. And I think, unfortunately or fortunately, that's the situation now. In the next 5 to 10 years in the United States, that is probably what we should put a lot of our focus into, is how do we align with people, other physicians or other groups. I don't even know what kind of groups there may be right now, right? It doesn't have to be a hospital. It could be a negotiating group, right? How do we align with one that is powerful enough to allow us to maintain quality of care, yet make us influential with the commercial payers and the government? That is that is a problem that's always been there, but it hasn't been a problem enough for groups until more recently. And now with the consolidation, the roll-ups, like you said, it's becoming a real issue. And so the groups that want to maintain quality have to find a way to get into the bargaining and negotiating sphere without necessarily selling out to a bigger conglomeration, if they can. That is where I think the focus on, agencies, private agencies should put their focus, because if they could manage that, then we could not only improve our quality of healthcare, but we can also improve the reimbursement and the quality of sort of attention given to good healthcare providers. Because that's the thing that gets lost. So you have good healthcare providers losing the fight. Eventually, you're going to have less good healthcare providers. And so then overall, even if the efficiency of care that's delivered is good, the quality gets worse and worse and worse. What you want is improvement in quality and in efficiency. It's very hard. And so, we see it now, what's happening in government. You have a whole agency trying to get efficiency, right? But at the expense of what? Some of these agencies that are giving quality to some people, but not necessarily everybody. So then it's like, who's more important? Right now, for us, our patients are the most important. So the best thing I can do is be present when they're there, give them good quality, but I still have to think on the backside, how am I going to take care of myself, this business, so we can keep doing that? Otherwise, we're going to get washed away.
And I think that what you touched on right there is that if you don't consider the customer service, if you don't consider the core business systems that are the engine that keeps everything running, then you can't continue to deliver great healthcare. But going back to that for a moment, one of the things, I've been fortunate enough to have some great conversations with C-suite level people in health insurance companies, and believe it or not, they're looking for those quality healthcare groups. And it's hard though, because you have all these groups that are coming to them saying, hey, we want better contracts, we want better contracts. And if I have 10,000 contracts with 10,000 doctors, that's a lot of work for them. And when they have those groups, like you just said, that they can deal and knock out 500 at one time, that creates efficiency for them, and they say that. But they're looking for great groups that are delivering high quality care. And the one thing that I've heard from them that I think is really great is that if you can start to quantify data, which I know when we're trying to deliver high quality healthcare isn't the first thing on our mind. Data around surgeries, we want to know, are we getting the right outcomes? What's the latest research? But if we're actually saying data over a population of patients and saying, look at these outcomes compared to the national average, look at our oswestrides, look at our activities of daily living improvements, and you can start to show these really industry-defining metrics that allow you to show improvements of your care compared to the national average or norms. There is a movement to pay for quality. And it'll be really interesting to see over the next few years whether we go to a model that actually does that says, if you meet these quality metrics, you get a better contract, and if you don't meet these quality metrics, you don't. Because that would encourage groups to say, we don't just need cost efficiencies, we need quality with those cost efficiencies. And so it does solve that problem a little bit. Have you as a group at all looked at the data associated with your group outcomes compared to averages?
Some of our hospital systems have provided that for us as a way to, at least for them, to improve the efficiency for care for certain types of operations, such as spinal fusions or anterior cervical fusions or microdiscectomies. But that's generally been hospital-based. But yes, we can see our data, and we've seen routinely that a lot of our data and a lot of our, length of stay and things like that is actually much less than, say, the national average. So we know that the care that we provide is good, and we would certainly love to be compensated for quality. But I think as much as these companies want that, These are huge companies
really
with
hard to talk to the right people.
lots of executives.
Yep.
And so if you had one person who could make sweeping changes and say, like, of course, this is what we want, then we might see some of that. But I am very fearful that these publicly traded companies whose revenues, are dependent on premiums, to pay more is to essentially reduce their profitability in the eyes of their shareholders. And that it puts them at odds with paying more for quality. Yeah. So because the only way that you can, in their minds, really do this is to make it more efficient and get good quality. But then they have to pick the right people to negotiate with. And unfortunately, right now, it's all a numbers game. Yep. The bigger the contract, that to them is more efficiency regardless of the quality.
And there's a lot of truth in that. I do believe that there's some really good people in insurance that are trying to turn the tide and to make changes. Would love it. But at the same time, it is a battle because you're going to see that over and over again, there's this huge issue with we need to be profitable. And if an insurance company needs to be profitable, they only have so many levers to do that. And so there's an easy button, and unfortunately that button gets pushed a lot, which is either lower rates for doctors or increase the number of people that they have through the system.
Right. Or cancel coverage completely, like State Farm.
Don't pay for stuff.
Yeah.
Right?
Let's not pay for fire insurance because you're going to bankrupt us.
California right now is going through a lot of that. So, I mean, I see what you're saying there. So let's move over a little bit to, you guys do have quality outcomes. I know that when we send patients to you guys do an incredible job. You have a great reputation in the community. How do you guys, we talked about how when you're in a small group, you can ensure that you're having those type of quality outcomes. What are some things you do to make the patient experience great, to make the quality of the outcomes great? How do you guys do that as a group?
I wish I would say that we all come together and say, this is how we're going to treat all our patients, but in fact, we don't. I think the reason that it occurs more organically is because we are all around the same sort of parts of our careers, and we've all known each other outside of medicine actually before we were partners.
Oh, no way.
So because of that, there's this very close familiarity of our personalities and how we act. And so I think when the group continued to be assembled, it was always, wait for the person that you think would fit in with us. And I think that goes to, the people who started the group originally. And then, as we've built over the past, 10 to 15 years, I think we've gotten to a point where everybody kind of thinks similarly, right? So it would be, it's not a conscious thing so much, right? But I do believe that if that were to change, I think, we'd have to have a discussion about that. But almost all of us routinely like being at work, as much as that sounds funny in what we do, but we like being there. We like talking to the patients, and we like being able to, provide them with the best care that we think is available. If there was something, even if it was a referral from, say, your practice, and we said, okay, this patient, needs this. If we didn't feel that was the case, we wouldn't just blindly do that. Because ultimately it's a reflection on us too. Yeah. If we do something and it doesn't help them, then you went through a lot of trouble and possibly a lot of pain to get not very far. And that doesn't help anyone versus, being able to explain to someone what the limits of medicine are for their condition at the moment, and then trying to do the best you can. And if you I think if you do that on a case-by-case basis, and it's hard to pay that much attention, but if you do that, then people will respect that, number one, and then your outcomes will be better, number two. And ultimately, that drives more people to you in the way that we have this very kind of family practice of spine surgery, just done at a very high level.
Well, it's actually an interesting philosophy for, this is a conundrum for entrepreneurs that are trying to build businesses. Yeah. And what it is I have a certain need in the business I need to fill. And frequently, it's looked at that way. There's an expertise hole. We need to go, okay, I need somebody that knows numbers. I need to hire an accountant. Yeah. What I think that you've done really uniquely is you said, we're not going to hire based off that way for our doctors. Instead, we're going to say, it's more about getting the right people than filling a need. Yep. And I think that when you do that and you really say being patient to bring on the right people and building around core people, you can actually build something really special because there's a synergy between the team that goes beyond just skill set and actually goes to personality and philosophy. And that's really special. So I did not know that about you guys, but it makes a lot more sense now because that's I believe one of the hardest ways to build a business is doing that because you have to be so patient. to make sure you have the right people rather than just saying we have a need now, hire. So congratulations on doing that, because I mean it. It's hard to do, but when you do it, it's magic, and
it is a more I'm not say satisfying, but it is a little more familiar way of doing things, right? Because it's more homegrown. And I think one of the things that a lot of us worry about is, while you might be able to do better financially in this bigger system, because eventually, like you can't be the town doctor anymore, right? It just doesn't work very well. At least the way that the mechanics of medicine are in today's environment. But we can do it for as long as we can do it, right? And the reason we're having this conversation is because everyone can see that it's not going to last that much longer.
That's true.
So I think we're aware of that, and we're happy, and we're very aware of the specialness that we have created, but we're not oblivious to the fact that we probably need to position ourselves in a way that we don't get swept away, as good as we are, as great a reputation as we have, because you can get swept away by a much bigger tide, right? The tide of healthcare is much bigger than DISC in Phoenix, Arizona. Yeah. So I think those are the discussions we are having now within our group, to be honest. We don't want to change because we like that special sauce and the interaction, but I think we have to do something to position ourselves so we don't get swept up. And if there's a way that we can do that and preserve what we have, even better, right? Because if we can run it even longer the way we have it, then it's very comfortable for us. But sometimes being uncomfortable is what you need to position yourself to grow.
I mean, because you can only survive so long in a really high tailwind or trend of decreasing payer rates.
Correct.
Right? Costs are going up. We have inflation.
Yeah.
Insurance is paying less and less. Yeah. Eventually, those two cross a point where it's you can no longer provide the service, right? And so being able to say, how can we continue to deliver great care to our patients? You do need to think differently, and sometimes it requires hard decisions, but that does bring growth. So let's, again, shift gears for just a moment. You all do a lot in the minimally invasive surgery space. I'd love to hear, as an orthopedic surgeon, you're coming out of school, we continue to see innovation moving at an extremely fast rate. I feel like there's new ways of doing stuff almost every year. You go to the conferences and it's like, hey, there's this new surgery here or there. What are some of the coolest areas of innovation that you all are doing at DISC?
Well, I think, there's definitely been this push for less invasive surgery in all of medicine. And specifically in the world of spine surgery. For a long time, endoscopic spine surgery, which is sort of the baby of my senior partner's father, Dr. Tony Young, that was his pet. But he was almost 20 years too early. The technical aspects and the instruments and all that stuff was very specialized, and it wasn't able to be mass produced. And so then if you can't have mass production of instruments, it's hard to have mass reproduction of technique. And so the interesting thing is now some of these other companies, sports companies that you didn't think had any role in spine, are now getting into spine. So I was just back in Naples, Florida at the second annual ever Arthrex endoscopic spine conference. And this time they had a third more surgeons than they had the year before, which is more surgeons than I've ever seen at any type of minimally invasive spine conference ever. And so there is this sea change where if the instrumentation can be more sort of standardized and you can get a better education rollout, then yes, the ability to do less invasive spine surgery, even with endoscopes and things like arthroscopes, I guess, is real. It's just that the barrier to entry is instrumentation and then obviously education. And these aren't things that are being taught in residencies generally. So you have to be willing, after you've been educated and you're practicing, to take on more education. And most physicians are. But at what expense? Is it expense of time? Is it now expense of surgical reimbursement? Because there aren't new codes that repay you more for these things. In fact, they may pay you less or pay you nothing.
Because they're more expensive because they're new.
So you have to be willing to, take a decreased reimbursement time out of your practice to get education, and the complications that come with new technology that you're not aware of because you haven't been trained to. Yeah. So unless that's, a common thing that most people want, the adoption of these lesser invasive techniques is going to be slow. Yeah. For us, because it's been in our practice, in the DNA, so to speak, for as long as it has, it's much more sort of commonplace to find a place for that operation when it makes sense. So in addition to all the other things that we do on a much more classic scale, such as spinal fusion, we will also do endoscopic techniques where we're trying to just relieve pain by cauterizing things, do sort of smaller operations to clean out areas where the nerves are being compressed, removing disc herniations so that maybe patients don't have to even go to sleep under anesthesia to get these operations done. So I think that that's the difference. That doesn't mean that's the only thing we're doing. It just means that we're able to do that too. And you give people, just like you said, this tailored experience. They come in and are like, you know what, we could do all of these things. But of the things that we can do, this one I think is going to suit you the best. And you let the patient play a role in deciding that. And again, outcomes generally are much better. It doesn't mean it's the only way they're going to be fixed, but it's an option. Yeah. But if you have one hammer and everything's the same nail, which is what a lot of surgeons end up doing, then you're going to do great sometimes. You're going to do really badly other times, and you're going to be mediocre most of the time.
Yeah, I think that's well said. And I think that there's an interesting thing that's happening that I don't believe has happened before. Maybe it has, and I'm just not aware of it. But I believe as we see these rapid advancements in technology and great doctors developing new techniques and new tools and everything like that, there's this interesting conundrum that happens of now where before it was, here's your option, this is what you do. Now it's, here's 1,000 different options. Which one's the right one? So in that area where you have to say, what's going to be best for my patient, and there's so many options and technology, every year there's more.
Yep.
There's this balance between saying up to date, but also saying what's going to work best for my patients and what do I have in clinical practice? How do you make that balance of staying innovative, offering new services that may be better, but also making sure that you have consistent quality outcomes?
That's a great question, because you're right. There's a knock on the door every week with some new pamphlet for some new product, new widget, to achieve, a better result than you have had. I think part of our experience is that we are fortunate enough also to have been utilized by the FDA for a lot of trials for new technology. So we get to be on the side where we select the patients that are going to do best for these studies. And so what we found is that being able to be on not only just the delivery side, but the sort of information technology side, the side of development of product side, the testing of product side, allows us to figure out who will do best. So I think that gives us a certain sort of edge that some other groups may not have, right? Because they only get access to the product after it's been released. We can kind of see it through its infancy, and these patients are different, right? These are patients that are selected specifically for FDA trials. They're outside of our normal practice pattern. They have to acknowledge that and sign, agreements with the companies. But from that standpoint, we get to see lots of different aspects of, a product going from, development, implantation, possibly success, possibly failure, and then ultimately, outcome. Yeah. And to be able to see that with new technology allows us to at least evaluate previous technology, in a different, set of glasses and glasses, just kind of figure that out and then apply that more appropriately. Because you're right, like I said, there's a way for me to do one type of operation in 5 different ways. I think what I found is being able to be associated with that other side, the development side and the research side, allows us to deliver that technology, more appropriately. And there's always subject to interpretation in spine, which is the beauty and curse of spinal surgery, and the reason that results are so important in spine surgery, right? It's probably the one that has the most amount of data collection because it's so confusing and so difficult. And the horror stories of everybody saying they never want spine fusion is a thing that is still real. And it's getting less and less as technology's gotten better and surgeons have gotten better at delivering the technology. But there's still a huge patient population that it's the F word to them, right? Fusion is the F word. And it's something that even as a surgeon, sometimes you're afraid of telling a patient because you're afraid of the connotation.
Well, and it sounds like your group has a really good way of balancing the innovation and experience window,
Yeah.
right? Because you need to have enough experience to do a procedure well, but you also want to have like the newest technology that can get better results, and you have to have enough experience with that. So that I call that a window, because there is a place where those meet, where you can have the experience to deliver great outcomes with the latest and best technology. So switching to kind of something that you said for just a moment, as you're looking at new products coming down the line, as you're looking at trying to deliver these quality outcomes, you talked about how spine surgery has a connotation and a reputation for, I can have this back surgery and still have excruciating back pain. I think this is a really important topic, because a lot of patients that may be considering surgery, that's their fear, right? Is they go like, well, what if, I have back pain now, but I'm reading online that you can have back surgery and you still have the pain. So there's good data, there's good research, you obviously have great experience in your group. Why does that happen, and what are some of the things that are being done these days to help decrease the amount of failed back?
When you're coming up in training and you hear the term failed back, right? It's sort of this blanket term for someone who still has pain after some type of back operation. And as I've gotten sort of further along my career, I think it's more of a misinterpretation of why the person had pain in the first place, right? Diagnosis tends to be the ultimate key in solving the problem.
Agreed.
And so I think the emphasis now for me is more on identifying where the pain is coming from as best as possible. Until I can do that, I can't really offer anybody some type of solution, right? And a lot of times the solution then is, I cannot do an operation to make your pain go away. And you are better served talking to an interventionalist or a pain management specialist or a psychologist or both or all of them together to figure out what it is that can be done to reduce your overall pain. But spine surgery, even with all the technology, is probably not your savior. And I had this conversation today with a woman who'd had multiple surgeries in her neck and her back as a second opinion from another state. And I was very frank with her, as much as she didn't want to hear it, to say, there is not something that I can reliably do for you to make that pain go away. So I will get more information. We will get more studies so I can see if I can identify really where the pain is coming from or why it's coming from, so I can give you better prognosis. It still doesn't mean that I'm giving you surgery. So I think that's the focus, is do you have the problems that we deal with on a day-to-day basis by your history? Have you attempted to try and treat them appropriately? Do you have imaging that reflects the same areas that you're complaining about? And has someone touched it, or have we touched it to give you some temporary relief that's really good in that area? If all those things fall into play, then yes, I think that we can apply some of these technologies and give somebody some relief without creating more problems. But if they miss one or two of the three things, right, the imaging, the complaints, or the attempt at trying to treat this non-surgically, then I think you're rolling the dice a little bit. And if you have none of those things, you're almost guaranteed to still have the same pain you have afterwards. And I think that's what, when the technology was still coming out and arising and we didn't know enough and people were just applying that blindly to all types of spine problems, you got a whole baby boomer population of people who had spine surgery who did not do well because they didn't get the diagnosis right. And that's still the same population that has children that now have spine problems. And those are the people that have heard all these things, and that's who we're dealing with. So it's our job to try and rewrite the book a little bit.
Well, I agree that the ability to diagnose is directly correlated with your ability to accurately treat, right? If you're treating a disc and it's a facet, radicular pain and referral pain. This is something that patients go, oh, I have pain that goes down my leg. And it's like, okay, well, they think it's, sciatica.
It's always sciatica.
It's always sciatica, right?
Everything's sciatica.
And so it's like, oh, I've got sciatica. And it's like, actually, this facet. But if you don't go to that level of, let's check, let's do some orthopedic tests, let's do some imaging, let's do something to accurately diagnose the causal factor, you're going to be treating the wrong thing if you don't do, or maybe you get lucky, but there's a chance of treating the wrong thing. And so 100% agree, your ability to diagnose what's causing the pain is directly correlated with your ability to get that outcome. But I think another thing that people, patients may not understand all the time is that surgery is, especially orthopedic surgery, is not done just for pain. And correct me if I'm wrong on this, obviously it's not my specialty, but we look at instability. If you have instability, it could or could not be causing your pain. But if you have instability, generally speaking, you're going to do a surgery to stabilize. If we have compression, we know oftentimes that does cause pain, but whether it's causing the pain that you're most worried about might not be the thing. And so if there's compression, meaning that, a disc bulge, there's direct pressure onto a nerve, generally speaking, you want to decrease that pressure, do a decompression, get the anything off the nerve that's there. If you've got really hypermobility and instability, you want to stabilize that because we don't want instability around nerves.
No.
You could have something else that's causing your pain, though, that's most bothering you, right?
Absolutely.
And so when they say, I have pain after surgery, you can have pain after surgery, but your hypermobility's gone. You can have pain after surgery, but your compression's gone. And that's not a failed back.
Right.
Like, that's not a failed surgery, I should say.
It's a failure of diagnosis.
It's a failure of diagnosis, but it's not that you didn't do a good job in the surgery. And so there's this whole other segment, though, of people having pain directly from types of surgery. So I'd love to talk about that a little bit for a second, because I think people don't understand. Like, I had knee surgery, I had back surgery, and now I have pain that maybe is different than I had before.
Yeah.
Why does that happen?
I think, when you look at the trauma of generally spine surgery, say lumbar surgery was the most common probably type of spine surgery that people are familiar with, is that, you have these large muscles that attach to the bone. And those muscles all have blood supply, and they're stabilizers for the spine. And traditional spine surgery, which involves elevating those muscles off of the bone, also creates devitalization of the tissues, right? And so many times what we'll see is people who've had these open spine fusions from years past, that all the muscle in their back is totally atrophied. And so even if they are decompressed, meaning they don't have the nerve compression, or they're stabilized because now their posture is better because you have screws and rods that are creating better sort of stability and alignment, it also still doesn't mean that they're going to be reliant on muscles to bend over and stand up, right? They still need to utilize those muscles. And if those muscles have been highly traumatized, I tell people it's like standing over a sink all day long. Like, if you have that gentle kind of tilt and you're constantly trying to stand up straight, those muscles are going to hurt, even if you don't have back problems. So then imagine if you have back problems on top of that, and now those muscles are traumatized. That is now a permanent or possibly lifelong issue where you're going to have back pain, as a result of the style of operation. That's not to say that minimally invasive surgery gets rid of that completely, but it certainly does less trauma.
Absolutely.
And so if you can fix the problem underneath, if you can get that old Star Trek wand and, fix the problem without, damaging the stuff on top, then obviously we're going to be better off. Yeah. But, you've got to crack a few eggs to make an omelet, as they say, right? It's kind of a joke. But you want to crack a few eggs, right, to make that omelet.
Yeah, so. Obviously, if you're going to do surgery, you got to cut something to get in there. But the less cutting you do, the more likely they're going to have that type of unassociated pain.
And that's been borne out from knee surgery. When I was training, there were still some folks doing mini open meniscal repairs and sort of more open ACL reconstructions. And you can see now within the last 20 plus years, almost all of it is arthroscopic. Yeah. So there's no doubt that results in faster healing, less pain, and less trauma. Agreed. Ultimately, it may not make for a more stable ACL, right? And they may eventually get to the point where they're still as good as they were with the lesser invasive stuff. But it also means that the potential for, casualties around that area is much less.
No, I agree with that.
Yeah, incidental casualties, yeah.
So we talked about the importance of diagnostics in treating care. There's been a lot of really interesting research as it pertains to AI and diagnostics. Mm-hmm. Do you believe that as AI gets better and better, you're never going... this is my belief. I don't believe AI can ever replace a doctor's ever, because whether it's surgeons, whether it's just the patient relationship and having that discussion, a big part of healing is connecting with people. Yeah. And an AI can't do that. Connecting, listening to them. Yeah. However, I do believe strongly that AI can assist us in being able to more accurately and more rapidly diagnose patients. What are your thoughts on, best applications of AI for your area?
For spine, I think probably if you could have AI do some secondary check on imaging studies, right, to confirm or not confirm the presence of, narrowness. Radiologists, as good as they are, will see things that we don't see, or they'll miss things that we see, since we both read imaging frequently. And so I think that a secondary check with something that goes over a checklist, and MRIs and X-rays, they're all data. They're all data, right? It's not subjective. It's very objective. The subjective part's with the interpretation. So AI can generally be used to do evaluation of data sets. And so imaging is perfect. Subjective pain and all that kind of stuff is still going to be subjective, right? The anticipation of how someone's going to react is all very human. Having a car right now that kind of drives itself, I understand its capabilities. It's amazing. The only way it can do that is with artificial intelligence and sensing. But it also cannot anticipate that I can see down the road that this guy just got on, is kind of swerving around, and he's probably inebriated. I know that, or I suspect that. Car doesn't suspect anything. AI doesn't suspect. No. AI only takes in what it has and then regurgitates something based on what with the data. So the thing about human nature and treating humans and treating their health problems is you still need anticipation, and you also need to read the patient. You need to understand their emotion that's tied to their health condition, because that goes into treating it as well. And if you just treat it like bone is bent and bone needs to be straight, that's fine. You can use AI to give you the implant you need to get to that, right? But the decision-making process to do the operation, which is the most complicated part of something like spine, is still difficult to accept that a computer is going to tell me, yes, this patient needs spine surgery, right? They could tell us, hey, this patient might benefit, and then the human component can go in and evaluate and say, okay, I agree, but you should also disagree. And if you just have AI do that kind of stuff with subjective sort of complaints, then you're going to have a lot of treatment issues. Then you're going to have treatment problems. So,
my hope for AI is that it allows our doctors to spend more time with patients, less time in waste and away from patients. There's a lot of work that's done that people don't realize that doctors do for patients, not in the room with the patient, right? So you look at whether that's documentation, whether it's authorization, whether that's all the stuff to try to get things paid for. My hope that AI would save patients' time and doctors' time, so that the time that they get to spend together is of higher quality and of higher duration, because we don't have to have all the other minutiae. So that's my hope for AI.
To your point, if you look at what procedures currently are done with computers, right? Look at ophthalmology, LASIK. It's not a surgeon doing LASIK. It is a computer. That is all AI. So it's been done for a long time. So the reality is, as much as I hate to think that I'm going to be replaced, I think my job is to figure out who is going to benefit from a procedure, right? And what procedure they might need that does the best job to solve their problem. But ultimately, the doing, right, putting a car together, should probably be helped by somebody who can guarantee that there's going to be a reproducible action, right? And the only thing that can really do that on a repetitive basis that doesn't get tired is a computer that's plugged into the wall. Same electrical output every time, right? Same amount of data processing. So yes, I think that AI would be great in the operating room to help do procedures. That's where I think ultimately it's going to get to. There'll be a fight to get there, but that's also another place, because you've gone beyond the human portion. Now we're just going into technical. We're going into an arm driving, just mechanics, right? So
assessing shape, what to do, how to cut, all that.
There is an art to surgery for sure, and complications arise, which is why when there's the Da Vinci robot, there's also a surgeon in the room plus somebody else. So still present, but that is, I do think, eventually something.
We get eventually.
I do think so, eventually.
Whether it's 10 years or 100, that is the direction we go.
My guess is it's 20, 25 years by the time it's actually really going. So hopefully I won't be practicing then, but it'll be interesting to see.
No, I love, we live in an incredible time where we're seeing technology really being a blessing in this space, but at the same time, like any new tool, it's trying to find the right way to implement it, how to regulate it, how to ensure quality. And I think that more than the advancement of the technology, it's what's going to delay the implementation of that. It's not actually, I think the technology gets capable before it's implemented because of the regulatory, how we decide to use it, the ethics behind it, all of that stuff. So fascinating area, but I think we're a ways away. People think, and some places will be a lot faster, like you said, radiology and reading a radiology and having it come back and then having the radiologist confirm it.
Yeah.
That could probably happen pretty soon.
Yep.
Right? But some of those other things, actually, I think it's already happening. But some of the other places like surgery and diagnostics, it's a whole nother world.
Yeah.
So kind of as we wrap up this last section of the podcast, we talked about how there's all these different surgeries. Sometimes patients have pain. We talked about how they could have pain and need surgery, how they could have pain after surgery. However, the better you diagnose it, the more likely they get an incredible outcome. Mm-hmm. But what about the patients that have a lot of pain? They come in and they see you and they're like, my doctor referred me over to you. Can you help me? And the answer is no.
Yeah.
And they're like, why can't I get surgery? I have this incredible pain. Can we talk about that for a moment?
So that's the most difficult patient, right? Because they come in with a preconceived notion that, for better or worse, whoever has sent them here...
surgery will solve this.
Right. They've been given this idea that I can't help you, but this person can. And oftentimes, that's usually because the person who's sending them doesn't know what to do with them. As opposed to telling them, I don't even think surgery will work. Mm-hmm. And just saying, well...
let's get another opinion.
Yeah, let's get another opinion. Because we'd be better served, and the patient would be better served if that was the communication on that side. But most of the time, just like the lady I spoke to today, it was, I've heard you can help me. And I had to say, I am going to help you. I'm going to help you understand why potentially you're not a good candidate for any more spine surgery, because you've had enough already.
Yeah.
So that's kind of how I kind of deflect that thought process. Because, we've had many, unfortunately, young people who've been in motor vehicle, I'm sure you've seen it, motor vehicle accidents, who there is very little to see, if anything, on their imaging that would explain how much pain they're in. Mm-hmm. And as a surgeon, generally speaking, we're sort of very basic in what we do. Just like you said, we stabilize things that are unstable, we decompress things that are compressive, and then we realign things that are malaligned. So if someone comes in and doesn't have instability, doesn't have compression, doesn't have malalignment, yet has tons of pain, they're not someone, I believe, who's going to benefit from surgery, right?
That makes sense.
That is my opinion. It's not necessarily the opinion of all spine surgeons, unfortunately, or surgeons in general. And there are plenty of surgeons who will operate on people who have lots of pain because they feel potentially they can get them out of pain, for better or worse. Yeah. I will tell you the outcomes of doing that, though, are highly equivocal.
Yeah.
And so my opinion is generally to just, as hard as it is to accept, tell them you are not a good surgical candidate. But that leaves a big vacuum, because then where do they go, right? Do you want to send them off to pain management, where there might be a never-ending loop of injections or narcotics? Not to say that that's the case, but I'm sure there are other less reputable pain practices that you know of that is the case.
Yeah.
So you don't want to turn the patient out and have that happen. So it's generally more of an educational experience. And you spend the most time with those patients. The ones that I spend the least amount of length of time, but maybe the qualities vary there, is there's an instability, there's compression.
This needs to be fixed.
They have had physical therapy. They've seen you. They've had an injection. They got great relief temporarily. And I can tell them, in a very short period of time and explain to them their problem and tell them what I think they need the most. And we can do that. We can get that done. And just because that may be a 5-minute appointment doesn't mean that it's not as fruitful as a 20-minute appointment with someone who doesn't need surgery, and to tell them why they don't. But people get so hung up on, the surgeon only spent 5 minutes with this patient. It's like, it's not about the time. It's about the quality of time and the communication. If you don't communicate with them and you just tell them what they need, they don't care either. They're going to just say that you're a bad doctor, right? Even if you are going to do a great job surgically, to them, you're not the best doctor, right? Well, what if there's another doctor who could do the same surgery but is nice to me? He's an excellent doctor, right? For better or worse, they're all human. People are human. If you just want a procedure, then fine. Sign up for a computer that gives you procedure. If you understand your problem well enough, you can self-diagnose and you can get it done, then you don't need the human component. But most people need a little hand-holding.
Yeah. I mean, if you think about it, if I take my car to a mechanic and they open the hood and they go tighten something on the battery and it works right afterwards, I'm not going to be like, you only spent 5 minutes with my car. You need to spend an hour with my car.
It works.
Right?
That's all. Yeah.
The core thing is you fixed it.
Yeah.
Thank you for fixing it.
Right.
And yes, customer service is incredibly important.
Yeah.
Connection is incredibly important. But the time spent with the provider is not the most important thing. The most important thing is the quality of that time. And so I 100% agree with that. Now, obviously, we'd love to spend more time with patients, but the most important thing is the quality.
Yep.
So, with DISC and everything that you guys are doing there, obviously you're really at the forefront of minimally invasive, helping patients with the least amount of additional trauma possible. One of the things we fight a lot with, like as a company, our company, Pain Doctor, and here in Arizona Pain, we're trying to really try to solve an opioid epidemic. We believe that collaboration with great doctors is a huge part of how we solve that, because as doctors talk, patients benefit. I truly believe that when we all have the pieces of data, patients sometimes tell one doctor one piece of the puzzle, tell another doctor another piece of the puzzle, and if we can talk, we can put those pieces together and say, this is how we help the patient. So collaboration, to me, is a big part of how we solve that. But one of the questions I love to ask providers that come in here is, you deal with patients in pain all the time. From what you've seen and what you know, how do you feel like we can help solve the opioid epidemic these days?
I mean, there is a role for opioids. They are, a naturally occurring sort of chemical compound that help block pain, right? And so if you have acute trauma, if you break a leg, if you get, shot or something like that, or you have surgical trauma, opioids are an important part of healing, right? It's the problem that arises when someone has a chronic amount of pain for a long duration without any obvious, source that is acute. Yeah. And so, these medications are not meant to be given on this chronic basis. They become less effective and they become more habitual. And so now you're creating a secondary issue for someone, right? It's a medical problem. Yeah. And so I think the more I used to say that, no one's died of, not taking narcotics, but people die from taking narcotics every day. Yeah. But it is, jokingly, a difficult pill to swallow for people who've been on narcotics for a long time. And I think that there's fewer and fewer of those people that come through the door now that have been on narcotics since 1985 from their primary care physician, because those guys have since retired and they're not getting access anymore. So I think slowly but surely it's happening. But I do think that there has to be some alternative, something that we can give patients other than just anti-inflammatories also, and Tylenol, and tell people to suck it up every day. That may be able to give them some amount of relief, and maybe that's topical, and maybe that's consumed like as a food nutrition product. I hope there is, right? And generally speaking, there's been more money in narcotics than there has been not. Yeah. So as that shifts, I guarantee you there will be another family of Sacklers that come out with something else that's not, and eventually maybe that'll be bad too. But there's going to be something else that comes out because there's too much opportunity. Yeah. Right, to control pain outside of narcotics now. And so hopefully someone comes up with something that's not addictive and not something that becomes something where they cannot, crawl their way out of, or become something that kills them because they take too much of it. Yeah. But if I knew, I'd probably move into that field.
No, true. I think that the reason one of the core reasons that is also not addressed is one of the reasons we have an opioid epidemic is in part because we have a pain epidemic. Like there is a massive amount of chronic pain. Yeah. And when you look at this, there's a lot of different corollary factors, not necessarily causal factors, but we used to be a lot more active. We sit at desks all day. Yeah. That leads to chronic pain. Yeah. Like we
joy,
health and food. Yeah. Like you look at food, and there's an argument to be said that as we mass produce food, the nutrient density goes down, and therefore we're not necessarily getting all the nutrients, and can that be correlated to pain? There's all these things psychological. We're exposed to all sorts of different types of, we're looking at our phones all the time, TV all the time. Does that have a psychological impact? So again, there's these corollary factors that we see, but in reality, we do see a lot of patients in pain, and if we can, this is why I believe what we do and what we do together is so important, is as we help patients get out of pain, in a very real way, we save patients' lives. Because if you're in chronic pain and you feel like you have no other option except to take an opioid, you're going to take it. Yeah. And at that point in time, when you get cut off and you can no longer take that, you're going to turn to something else to try to help with that pain. And I feel like a lot of times that's where it leads to desperation, and that desperation can lead to these deaths that we're seeing. Yeah. And so as a doctor community, it's really important for us to say, how do we help these patients get out of pain? How do we deal with the mental, emotional, and psychological components that are affecting these patients' lives that are in chronic pain? But one of the core things I believe, as I said at the beginning, is education. And as we have these conversations, we talk about this, we make it more normal for patients to be able to hear doctors trying to solve this problem. I do believe that over time, as you just said, we're making good momentum, but over time we will solve this and help a lot of patients. So
I agree.
With that being said, we love the fact that we get to collaborate with you and work with you, and this has been a fantastic conversation. One last question, just out of curiosity. If you were not able to be an orthopedic surgeon, what would you be?
It sounds funny, but I've always dreamt of being a professional bass fisherman.
Really?
Yeah, I love
Fly
fishing.
or
no, like just like on a boat. I love fishing. It's
Okay.
it's something that if I could do every day, as soon as I quote unquote retire, that's my plan to go fishing.
Go fishing?
Yeah,
That's
I love
fantastic.
it. It's like Randy Moss.
There it is. Well, thank you so much for coming
You're
on.
welcome.
Really
Thank
appreciate
you.
having
It was
you.
my pleasure.
Alrighty.
Thank you. Thanks, everybody.